There's quite a few things we don't know about the RATIFY study. We know that the addition of midostaurin to chemotherapy produced a superior overall survival, but with a 717 patient study, there's a lot to learn. Some of the ancillary data has been coming out over the past year or two, largely led by Professor Donor, or the professor's Donor from Ulm, but many other people have contributed to that. Let's see. Well, number one, do the ELN prognostic subgroups have relevance when looking at the RATIFY trial? The answer is yes. Do some people relapse with FLT3 wild-type disease? Yes, particularly if they have been exposed to the midostaurin arm of the study. Midostaurin may exert some selection pressure against the FLT3 mutations, because it seems like most of the patients who relapsed on the placebo arm did so with FLT3 disease. So one of the things we don't know about the RATIFY trial is the answer to the following question: why patients who got a transplant during first remission and who were exposed to midostaurin did better than those who got a transplant in first remission and were exposed to placebo? The answer might be that those who got the midostaurin and the chemotherapy were able to achieve a lower level of disease burden than those who didn't get the midostaurin. That remains an unanswered question, and is a hypothesis which can possibly be answered by looking retrospectively at some samples we have from patients who were in remission and the two arms of the RATIFY trial. Another thing we don't know about the RATIFY trial, and we'll probably never know, is the importance of maintenance therapy. The FDA asked us to do a 2x2 randomized trial design to answer that question before the trial was even mounted. We didn't feel that was feasible, but of course in the tincture of time it would have been nice had that been possible, because we still don't know if maintenance is required. In the European medical authorities have approved maintenance therapy with midostaurin. The American FDA has not. I think each has good points to make about their rationale for that. But I don't think retrospective looking at the data is going to really answer that question, unfortunately. I will say this: if it was up to me, I would give maintenance therapy, because it was a package deal that led to an overall survival, as best we can tell. On the other hand, most patients should probably have a transplant in first remission. So the maintenance question, at least the pre-transplant maintenance, is probably not relevant. What is relevant is post-transplant maintenance, which is a completely different question that wasn't answered by the RATIFY trial.